All right, I guess we'll get going. Okay, good morning. So I just wanted to start today by going over the intracardiac catheters and just to remind everybody, because sometimes I think I assume things that are not true. So this is the LAO view of the heart. We use this, of course, as well as Carto. It seems like every time we do a case, the tech has closed the computer before he's made a picture for me. So just to remember the basic electrophysiology catheters. So we have one catheter that goes in the coronary sinus. And remember that this is sort of near the mouth of the coronary sinus, and this is out towards the left lateral position. And remember that when we look at this view, we think of the mitral annulus being generally here and the tricuspid annulus here in the LAO view. And this is why we project the LAO both on Carto and on fluoro so that we can see, basically see our orientation relative to the AV valve. Now, why is that important? Because when we're ablating people with tachycardia, we believe that the best place to put the catheter is on the AV valve because most pathways are smallest or thinnest at that location. In other words, it's easiest to ablate along the AV valve rather than in the atrium or ventricle. Similarly, we think it's less injurious to the heart to burn on the fibrous ring of the annulus rather than directly in the myocardium. So here's our coronary sinus catheter. You know that I typically will put mine from above, but Dr. Love will put them from below. And I think it would be fair to say that the majority of electrophysiologists actually do put them in from below, using a catheter that is deflectable because it's challenging. You have to go posteriorly and leftward in order to get in. So you need a catheter that has deflectability. We typically have a catheter in the right atrium. Some laboratories will just use the ablation catheter as their high RA catheter temporarily when they're doing these procedures. There's typically a catheter in the His position. This is an image for patients, but really it's sitting right on top of the His. We have a catheter in the right ventricle for both pacing maneuvers as well as for safety in the event that there were AV nodal injury during the procedure. Those are the standard catheters. Okay, so this is basically what the intracardiac images look like once we're in the lab. And so I thought it'd be worth going through. So typically we'll project 3 or 4 leads of the electrocardiogram on the top. And just to remind everyone, all the leads that are being displayed, the intracardiac leads and the EKG leads, are all simultaneous. And so if you're ever trying to sort of understand what's going on intracardiac, it's always good in your mind's eye to look at the intracardiac and time it out relative to the surface ECG, which of course you're very familiar with. Now, the one thing that makes it a little different looking is that we typically run the paper speed at about 100 millimeters per second, sometimes even as fast as 200 millimeters per second. And of course, regular EKGs are run at 25 millimeters per second. So everything is very stretched out and appears a little bit abnormal or unusual. But the reason, of course, that we do this is that we're measuring things literally in milliseconds. And so we need to really be very careful when we're making intracardiac measurements. And so we do need to run it at a fast speed. And electrophysiologists typically get used to looking at these things at this speed, just as we would get used to looking at an EKG. Now, when you're looking at an intracardiac tracing, the way that we generally display it in our lab is that we display everything all at the same time, meaning we have both the ablation catheter and all the other intracardiac catheters all at the same time on the screen. They don't all have to be displayed at the same time. In some other labs that I've worked in, we don't put the ablation up on the screen until the time that we're going to do an ablation. And the theory behind that is that the signals will just be larger. There'll be less crap on the screen, so it's a little easier to focus on what's happening. But the other side of it is that it's just simpler to just have one set protocol, which is how we generally do it here. So we have 4 leads, and then typically in our lab, we display the distal ablation and the proximal ablation. And it's important to remember that the order in which I'm demonstrating these leads and in which we do it here is different in every lab. Every lab does it differently. And so particularly in reference to when the one day that you take your board examination or whenever you look at questions about intracardiac, you always have to look at the legend on the left-hand side of the screen, because although Barry Love and Robert Pass display their signals similarly like this on the screen, in other labs, they might put the RV at the top. They may display the distal coronary sinus to the proximal coronary sinus. It can really be displayed in multiple different ways. And so it's important to just always look at the left-hand side of the screen to make sure that you understand what each channel looks like. Similarly, in our laboratory, we display the right atrium in red, the His in yellow, the coronary sinus pairs are in green, and we pick the RV purple. Purple. But that, of course, is completely random. I mean, honestly, it's just the reason that I display it this way is because when I was a fellow 23 years ago, this is how Dr. Walsh and Dr. Triedman and Dr. Saul used to make their colors. And so I just sort of adapted it. Some people, some labs don't like to use colors at all, and they just do it all in white on black. So I just think it's easier to distinguish the pairs by putting them in different colors, but there's no right or wrong. And oftentimes questions like this that you'll see on board examinations will be in black and white. So it's really most important to understand what the signals are, not so much what the colors are. But in our lab, we do that just for ease of following it. So we have a catheter in the high RA. And again, so this is in sinus rhythm. And so you can see the P wave is a little strange looking, but it's the patient's sinus P wave, and it's simultaneous with the atrial electrogram. You notice that the P wave actually is starting before the atrial electrogram, and that suggests that the high RA catheter isn't that high. It's not exactly near the sinus node, because if it were very high, you would think that it would be pretty much on time with the onset of the P wave. So this is probably not exactly a high right atrial catheter. Then we have distal, mid, and proximal His pairs. Now, in our laboratory, we use a quadrupolar catheter for His, and we record from the distal electrode to the second electrode, from the second to the third, and from the third to the fourth, in order to create 3 His electrograms. But some laboratories will put a hexapolar catheter with three separate independent bipolar signals. Some will put a hexapolar and display 6 His channels, and different electrophysiologists feel differing levels of comfort with how many of the channels can show a His depolarization or deflection in it. There's a very famous electrophysiologist named Mark Josephson, who sadly died a year or two ago. Very prominent guy, very prominent textbook that he wrote. Apparently in his laboratory, you had to have like 8 or 10 pairs with a His on it, or else you couldn't get going in the case. And was very adamant about that. So then we have the coronary sinus catheters. And this is where a lot of times when you're looking at tracings from another lab, particularly if you're one day doing a board examination, take great notice of the direction in which the coronary sinus pairs are displayed. In our laboratory, we go from proximal to distal. Now, you notice that we're not being very consistent here, right? We're doing distal to proximal His, but we're going proximal to distal coronary sinus. So, this is just really effectively a random choice based on what we're used to seeing, but not uncommonly, this can be reversed. I remember when I took my board examination, they did that very thing. They reversed it on the tracing. And in fact, I remember there were 2 questions on 2 sides of a piece of paper. At that time, the test was in a booklet form. And on one page, it was displayed one way, and on this next page, the other. And because I knew that I had to get all the EP questions right, because I wasn't going to get all the echo questions right, I spent a lot of time on it, and I couldn't understand it until finally it dawned on me, after I had devoted over a minute to the question, that they had changed the direction of the signals in the legend. And then finally, there's a signal in the right ventricle. And as you would expect, the right ventricular signal is the latest of all of the ventricular electrograms because it takes the longest to go from the atrium down to the distal apical right ventricle. And so we see here in the proximal CS and in all the CS pairs, we have an atrial electrogram and a ventricular electrogram because the catheter is sitting on the AV valve annulus, nicely poised between atrium and ventricle. Okay, so any questions about that? Okay. So here we are in a case, and we are rapid atrial pacing at cycle length 440 milliseconds. And so let me ask Dr. Candid what she thinks about this. What's going on here, Tulsi?
Okay, so there is, so after the, let me just take a look. Well, I know that adenosine blocks conduction across, or yeah, through the AV node.
Mm-hmm. And what does it do to accessory pathways?
It does not, yeah, so it does not block conduction through an accessory pathway.
That's exactly correct. Okay, so now you have elaborated perfectly what adenosine should normally do to both AV nodal conduction and accessory pathway conduction. So what do we see here, and what does that tell you about the mechanism? So this patient has a history of SVT, and we're V-pacing at 550, and we give 12 milligrams of adenosine, presumably causing block in the AV node. So what happens? What do we see here, and what is that? What's the implication of this?
So in the first beat, there's VA conduction.
That's correct. So just so everyone's on the same page, here we're pacing the ventricle. So we see all these V's, and then we see A's afterwards. And also I'll mention that the earliest A is in the HISP pairs, which means that either we're going up the AV node, or alternatively, we're going up an accessory pathway that is very close to the AV node. Notice how late the atrial interval is in the high RA compared to this. Okay, so yeah, so we have, just as you said, we have a V and an A. And then what happens on the next beat, Tulsi?
There is no VA.
Right, all we see is V capture, but no A. And then what happens on the next beat?
There is again VA conduction.
And then
no VA conduction in that beat that you're pointing to.
Right. So basically what we're seeing here is a form of VA block, right? We have basically 2-to-1 retrograde VA conduction. So just as you said, you know, if you look here where I put these little stars, there's no retrograde atrial conduction on this beat or on this beat. So we're seeing sort of 2-to-1 VA conduction. So what would that tell you if you're at the beginning of, we usually do this fairly early in the electrophysiology study. So if you saw this, what would this tell you in regards to the likelihood of having an accessory pathway mediated tachycardia?
Well, because adenosine does not block in an accessory pathway, there is no accessory pathway.
That's right. Because we're seeing VA block with adenosine, that is very suggestive of the fact that the patient has no accessory pathway. So if you had a patient who is not pre-excited and had this observed finding with V pacing and adenosine, what is the most likely etiology for their SVT? Let's assume they had documented SVT. And let's say even that it stopped with adenosine clinically.
I don't know.
Is that AV nodal reentrant?
Yeah, So that means that it's most likely that the patient has AV nodal reentrant tachycardia. Now, it's not a guarantee, of course. Why is it not a guarantee? Because some pathways actually are adenosine sensitive. So it's kind of like for every rule there's a break to the rule. There's an exception. But so when we're doing an electrophysiology study, right, we're trying to gather our evidence piece by piece in terms of understanding what the mechanism of the tachycardia is. We would not, for example, use the evidence that we're looking at on this screen as definitive proof that the patient has AV-NRT, but it would definitely go in the, as we're building our case, like lawyers here in the cath lab, to figure out what actually is happening in this patient. The fact that there's a ventricular-atrial block with adenosine would certainly be one check mark in the AV-NRT box. Now, again, for example, people who have PJRT, which, as we all remember, is a form of ORT with a slowly conducting pathway, sometimes those pathways can be adenosine sensitive, and a small percentage of regular accessory pathways can be adenosine sensitive. So we wouldn't use this exclusively as evidence that the patient has AV-NRT, but it would certainly be very suggestive of the absence of an accessory pathway. The other thing I'll mention is you see this ventriculo-atrial time here. This is a fairly long VA time for a pathway that's right near the AV node. Now, there could be a pathway in the lateral position that makes it look like this, but the fact that the VA time is kind of long-ish here, although earlier than any of the other sites, also kind of argues against it being a pathway, but it's not a guarantee. Okay. Let's move on. So this is an electrocardiogram obtained in a patient in the ICU. And what is happening here? So let me see if Dr. Zawani has any thoughts on this.
Yeah. Hi, Dr. Bass. So, morning. So, I'm looking at the tracing V1 and lead 2, and I'm seeing a pacing spike before each QRS, and it's after the P. So I think we are V paced.
Is this a dual chamber or a single chamber pacemaker, you think? Do you think that, so how would you know if it was single or dual chamber based on this tracing?
So maybe like a variation in the heart rate that could be more of a sign of a dual.
Yeah, that's true. But why would there be variability in the heart rate in a dual chamber pacemaker? I agree, that's true, that you would see more variability.
Because of the pacing of the O chambers.
Well,
the asensing.
Right, because there would be asensing, right? And so you're basically saying that normally the sinus node in patients is variable depending on the level of adrenergic stimulation. And so the heart rate will change based on sinus changes. And so the V-paced rate would vary with the atrial rate. In other words, because in a dual chamber pacemaker, there is AV synchrony, you would basically, in someone with a normal sinus node, essentially have ascents V-paced rhythm. And so if the atrial rate went up, like with exercise, we would expect the V-pacing rate would keep up with it and vice versa. So is that happening in this? Is there AV synchrony in this patient?
I believe so.
How would you know if there is, based on this tracing?
So I think that
I mean, the key is that there's a P wave, right, before every paced complex, right? There's
Yeah.
AV synchrony on the tracing, right? If it were just straight VVI pacing without AV synchrony, the relationship of the P waves to the paced complexes would vary throughout the tracing, right?
Yeah.
So the fact that we see a P wave before every QRS and that it's has a PR that's kind of similar is actually suggestive. Now, one of the interesting aspects of this tracing, though, is that we notice that the QRS isn't exactly the same on every paced complex, right?
Yeah, it's different. Each beat
A little
is
bit different, right?
Yeah.
Any thoughts on why that might be?
So so one thought is that if the patient is having his own his own QRS, and then the other one is the paced one.
Right. So probably this patient has some of their own conduction. And so what happens is, think about where the pacemaker wire in the ventricle is. Let's say, for the sake of discussion, that the wire is towards the apex of the right ventricle. So if somebody has intermittent conduction, and the AV conduction is, let's say it's slow, but not, so you have a longish PR, but it's not awful. What can happen is that, the way the pacemaker is programmed is you basically tell the pacemaker, let's say 110 milliseconds after a sensed atrial event, I want you to pace the ventricle. And so what could be happening is that because the ventricular lead is so apical, it doesn't actually sense the depolarization of the ventricle because the impulse from the AV node down to the apex of the right ventricle hasn't yet happened. And so it's pacing basically on top of a depolarizing ventricle from the AV conduction. And so you get this sort of a mixed complex. So you could argue that it should not pace here, right? Because this may be a conducted complex and we would prefer it not to. But the problem is that because the lead is so physically far from the actual AV node, so far down on the ventricle, it actually doesn't detect a ventricular impulse in time for the other part of the ventricle to have already started depolarizing. So there's basically a fusion of both natural conduction as well as the patient's pacing. Does that make sense?
Yes, thank you.
Yeah. So it's interesting tracing, I think. It's an old tracing. Okay.
I have a question about that one.
Yeah,
so
sure.
If you're dealing with that then, and that's happening, would you then lengthen like the pacemaker's like sensing time so that to try and get rid of, like, if we want to try to preserve the patient's natural conduction, so that that little bit of extra time the pacemaker then is able to sense that
Yeah, you absolutely. That's an excellent question, Molly. Yeah, you could definitely extend the PR interval or the AV delay so that to try and enhance the pacemaker's ability, the patient's own ability to conduct, right? Because as a general rule, we think that you're hemodynamically going to be a little better if you're conducting on your own versus paced. There is a certain level, though, of like if the PR is, say, over 300 milliseconds, I'm not sure if that's really better than having an AV delay that is more physiologic. In a lot of cases, though, it's actually not possible to extend the PR long enough to avoid the pacing. The other thing is that if somebody's AV conduction is varying, and we talked about this a few weeks ago, patients generally don't like that sensation of conducting and then pacing and conducting and pacing. Now, the other option is that we could turn on a so-called MVP or minimized ventricular pacing modality, where the pacemaker is essentially an AAI pacemaker, allowing for a very long PR interval. And then when it detects the absence of a QRS following a P wave, it will then revert to DDD temporarily. And then typically after a defined period of time, like 30 seconds or 60 seconds, if it detects that conduction is occurring, it will actually revert back to an AAI. And the goal of that approach would be to basically pace the ventricle as little as possible, which is probably better physiologically and certainly saves battery life. But as I've explained to you in the past, sometimes that's hard to do.
Yeah, that's the uncomfortable part where.
Yeah. So you're right. The first thing you would do if you saw this would be to extend out the AV time as much as possible to see if you could get, right, I think if we could have a PR of 200, but it was 100% A-sense V-sense rather than A-sense V-pace, that probably is preferable. It would be interesting to see if this patient had an A-line in place, if one of these complexes actually was better than the other in terms of blood pressure and stuff. So it's a good point you made. Thank you. Okay, this is a 7-year-old with an irregular heartbeat. And most important question is, what is this diagnosis? And I'm going to turn this over to, why don't we ask, let's ask Dr. Ella Faturi, soon to be a cardiology fellow somewhere lucky in the United States.
Good morning.
Good morning. We haven't seen a case of this in a while, by the way. This is an old tracing from an EP conference from like 17 years ago that I gave, but an oldie but a goodie.
So it looks like the heart rate is around 70 initially. I would say initially on the limb bleed it was about like almost 70, I would say. Then it keeps on narrowing down. I can see that the P wave looks like a sinus P wave. The axis looks it's positive on lead 1, positive on AVF as well.
So is the rhythm regular, Mahmoud?
No, it's not regular.
It's not.
It's more, no,
Is
it's
it,
irregular rhythm.
Is it
And it is-
regularly irregular or irregularly irregular?
It is irregularly irregular.
That's right. So now if you didn't even have this tracing, and I just said to you, I have an EKG of someone who has a narrow QRS with an irregularly irregular rhythm, what would you think is the most likely diagnosis just based on that verbal description of the ECG?
I don't know actually.
So we would normally say that sort of sounds like atrial fibrillation, right? Because in AFib, the atrium is going very rapidly and there's variable AV conduction. And so it is very typical in AFib that as opposed to say atrial flutter, right, where you have a constant atrial rate, and there's usually a consistent conduction, or at least in short periods of time, like let's say 2 to 1 or 3 to 2. And so the AV time is relatively regular. But in atrial fibrillation, you'll often have an irregularly irregular rhythm. But is this atrial fibrillation? Now you have the tracing in front of you. So do you think this is AFib?
I don't think so. I can see P waves in most of the QRS prior
I
to
agree.
most of QRS complexes. Yes.
Yeah, I agree. I don't think this is atrial fibrillation either, right? Because just as you say, there are clearly some beats at the beginning of this tracing and sort of towards the last third that look normal. But then in between here,
can it be like an EAT?
It could be EAT. That's a good differential diagnosis. But I think if you look at these leads, you could make an argument that, so in EAT, there's typically 2 P waves, right? There's the sinus P wave and then the ectopic atrial P wave. But in this case, it looks like there's more than 2, right? So you have the sinus one, you have this kind of tall P wave, this little, it's maybe a sinus one. This P wave is sort of biphasic here. So I would say that there's at least 3 different P waves on this tracing. It's not a great tracing, but it looks that way. So what would we call this if you have multiple different P waves? It's not fib, it's not EAT, because we've already explained that EAT, there would be a single P wave morphology. So what do you think this is?
I'm not sure if I call it SVT.
Well, it's a form of SVT, but really the proper term for this is a chaotic atrial rhythm. Sometimes in the adult literature, they would call this multifocal atrial tachycardia, but in pediatrics, we refer to this as chaotic atrial rhythm. And that is a rhythm that is characterized by multiple, typically 3 or more distinct P wave morphologies with an isoelectric baseline. So that's how you distinguish it from fib or flutter, right? If this were fib or flutter, we would see lots of P waves throughout the entire tracing, but I think we would agree that there certainly are periods during this where we see what appears to clearly be a clean baseline without evidence for fib. There's often variable tachycardia rates with an irregular P to P interval despite discrete P waves. And we don't really know why people get this arrhythmia, but typically it's multiple competing automatic foci, could be reentrant loops, it could be a triggered mechanism. Nobody really knows the exact etiology electrophysiologically. Most people who have chaotic atrial rhythm do not have congenital heart disease, but often have some other medical problem, such as also have some medical problem like respiratory illness. It's not uncommon in the adult world. This arrhythmia is seen in people who have pulmonary illness, like the classic example is someone with a pulmonary embolism can have multifocal atrial tachycardia or chaotic atrial rhythm. This is not a rhythm that is responsive to DC cardioversion or adenosine. And it's a dangerous rhythm. It can be associated with sudden death in a real percentage of young patients. And it's thought to be due to bradycardia, but I'm not really sure if that's just due to toxicity from medication used for it. And typically, one needs a lot of antiarrhythmic therapy for this. There's not really a great ablation approach to this. It really is medical therapy. And it often goes away with time. And I've seen this rhythm a handful of times in young people. I always remember this one patient who came into the hospital nearly arresting. It's an interesting case. The patient was seen in an office in northern New Jersey, and the pediatric cardiologist wanted the patient to come to Columbia, where at the time I was working. And the ambulances will not take a patient across the GW Bridge into Manhattan because it's a different state. And so because there were no real great pediatric emergency departments, he actually made the decision, the cardiologist, to tell the grandfather to take the child in his car across the bridge to Columbia. And I remember we had a lot of discussion afterwards about whether that was the right thing to do. Thankfully, the patient did make it alive to the emergency department, was very, very sick, had an ejection fraction that was unmeasurable. And actually, we ended up, heart rate was very fast, over 200, ended up using diltiazem and amiodarone to control the heart rate. And eventually, the child went home on a very high dose of amiodarone, and it actually resolved within about, at the time, the patient was like 6 or 8 months of age. And in that case, at that time, this is like now almost 20 years ago, intravenous calcium channel blockade like diltiazem was very strongly cautioned against in small children. But at the time we were writing our paper, or we were thinking about writing a paper on IV diltiazem, which we ultimately did write up. And we had observed that it was relatively safe in comparison with verapamil, which we would never use in a young child. And in fact, this child, who at the time was certainly less than a year of age, was probably like 7 months old, tolerated the diltiazem fine and got a very nice heart rate response almost immediately with an improvement in blood pressure and perfusion, and allowed us time to get a more chronic agent like amiodarone on board. Any questions about that? All right, I guess we'll stop here. Thanks, guys. I hope you found this somewhat useful. Very good interpretation this morning. Very impressed. Good work. So I'll see you in conference in just